Hello, and welcome to our brand new innovation series of webinars where we invite you to meet our game changers. So these are key opinion leaders who've been pioneers in adopting novel diagnostic solutions, driving change, and ensured improved patient outcomes as a consequence. So in this, our first episode, we are joined by Stephen Kidd, as you can see, who will be discussing innovation in respiratory diagnostics with syndromic testing and BioFire respiratory panel and BioFire Spotfire. We're also joined by Kate Donachie, who will be keeping an eye on the Q&A function for your questions. And she'll also be available at the end for our live Q&A, where you can raise your hand. We can unmute you so that you can speak to Stephen directly. So even if you pop something in the Q&A function, we'll just be dealing with all questions at the end. Just to let you know as well, because this was a pre-recorded event for the main body, you'll now be able to watch the video with full interactive access and stop and start your own video. But just to be clear, this won't affect the video for anyone else. But please bear in mind that at the end of the runtime on my screen, the live Q&A will start. So the full video will, of course, be made available on YouTube for you to view afterwards if you wish to go back to it. So without further ado, we will kick off with the video.
We'll start with the very easy one then. Tell me a little bit about yourself.
A little bit about myself. Okay, so my name is Stephen Kidd. I am a clinical scientist in microbiology and infection, lead healthcare scientist at Hampshire Hospitals, so a privilege to do that position. So I'm halfway through my consultant training in clinical scientist, so I'm part of the higher specialist training cohorts, which is pretty full on, but very rewarding.
How did you end up here? And tell me a little bit about this hospital and kind of what you're about and your patient cohorts. And
yeah, so Hampshire Hospitals is a foundation trust that comprises three parts. Winchester Hospital, so the Royal Hampshire County Hospital, and then Basingstoke and North Hants Hospital, and then the smaller kind of Andover War Memorial, more of an outpatient, and the three of those are part of the same trust.
We're here to talk about innovation, and I suppose it would be really nice to get a sense of what the situation was beforehand. So what kind of led to kind of bringing in this change, and kind of to get a sense of the standard of care, I suppose, beforehand, and what needed to change.
Innovation is something that I've always enjoyed. I'm a bit of a non-conformist, so to speak, a bit of a kind of a disruptor in that regard. Some might call a pain in the bum, but I think you always like to improve things, no matter where you go. That can be seen as a hindrance, and it can also be seen as a positive thing. So, so one of my kind of passions and skill sets is in molecular diagnostics, and it's something that I was asked to kind of set up at Hampshire Hospitals. I was the first clinical scientist in microbiology, and it's one of the things that they wanted out of that was to kind of grow the molecular diagnostic area. It was seen as the future, and so I was asked and tasked to kind of evaluate what we had and see how we can improve things. And one of the areas which lends itself very naturally to molecular diagnostics is respiratory infections. It's a very easy sample type to use, either a swab or a nasopharyngeal aspirate, quite straightforward matrices to work with. And so we looked at kind of organising how we can improve our testing. Our cohort of patients, we've got about, I don't know, it always fluctuates slightly, but around about 900 beds across the two main hospital sites, with one laboratory, microbiology laboratory, at Basingstoke. And so therein lies the first challenge is site with no testing, transferring samples across. So improving turnaround times is something that molecular diagnostics can really help with, because assays are faster than either sending them away to a reference lab or bring in something like point of care. So we started to kind of map out. And interestingly, the first respiratory tests we brought in kind of point of care were lateral flows. Everyone's now familiar with lateral flows after COVID, but we've been using that type of thing for a while, and that was kind of the forerunner to PCR molecular diagnostics that we're kind of running now. And kind of, where do you feel the biggest impact can be? People will automatically say, well, ED during the winter, big pressure. And then obviously with that pediatrics, kids are always snotty, they share bugs really well. So peds is always an area which are really grateful for that kind of thing, especially with RSV and the flu. And obviously now bringing COVID, we've got a whole new thing. So COVID forced us to up our game and think outside the box. And we can talk about that.
Yeah, so do tell me, when you were thinking outside of the box, what was the changes that you kind of almost were forced to implement, but for the better?
I think there was a lot of centralising of testing for COVID, because initially there wasn't really any reliable point of care devices that were of a sufficient performance, because that was quite highly regulated. So we all kind of almost went backwards, whereas previous winters we'd used kind of lateral flow, and then lateral flow with a reader, and some kind of more simple, rapid single PCRs that have been in our ED departments, our paediatric ED, our paediatric clinics. So that was the kind of thing people were asking for straight away. Oh, have you got COVID point of care? And we said, well, actually, no, not at the moment. So it was all about having to think, well, how can we offer rapid diagnostics? Because, the pressures were around status of that patient, so they could be cohorted correctly. We want to make sure people were going to what were then hot and cold wards, COVID positive, COVID not. Children were even harder because they came really like diffuse symptoms. So one of the things we wanted to do is centralizing everything in the laboratory, but then we thought, well, actually it's a bit slow for what we need. And bed management was really critical on the pressures on the front door. So how could we improve our patient flow? So we started to look at near patient testing, so bringing the testing out of the lab, but not quite as close as point of care traditionally would have been, because we didn't want to add a burden to the staff on the wards. So we set up two what were known as COVID essential services laboratories, rapid labs near patients, and opened up on Winchester site. So we'd remove that kind of delay in sending to our main lab in Basingstoke. And I think that was the initial thing. Well, actually, this is something that can work really well, a model. And then obviously, as the pandemic developed, we moved to 24/7, which we've never been 24/7. So we moved 24/7, so to kind of work around the clock. Obviously, slightly smaller pared down team, and then seeing that benefit was really impactful on patient management, patient placement, patient discharges, which are always critical when you've got limited beds. Not wanting to back down from a challenge, last year the government was like, well, we've got some money. We feel that acute respiratory hubs are something that can sit between primary care and ED that can maybe help with our winter surges. And we were like, sounds great. How do we do it? So obviously some guidance came down. Obviously they've got to be resilient, they've got to be safe, they've got to be compliant with regulatory ways of working, quality, clinical safety. This was kind of briefed out, and then our colleagues in unplanned critical care were like, right, let's see if we could get something in our hospital or close to it. We'd had a good relationship with that because we helped set up a very early GP COVID kind of like testing hub right at the very beginning of the outbreak, just using lateral flows really. And then kind of pioneered what's known as kind of virtual wards. So obviously during the COVID pandemic, we were like with everyone, no beds. So what do we do with patients who need to come in, maybe aren't quite sick enough to need to be admitted to push someone else into another area with COVID, but they still need to be safeguarded? So we had what's known as a telemedicine team. So if someone was deemed to be ill enough to might require monitoring, they're sent home with a pulse oximeter, so measuring your oxygen, having someone ring them up every day to check on them. So they were admitted to a virtual ward. That's exactly what it says on the tin. And so we then gave them, so they could be COVID positive, and they're admitted to a virtual ward, and someone just keeps an eye on them virtually. That worked really well, and we showed some good evidence that that stopped admission to hospital, it stopped readmission, and the kind of quality of life of these patients was really good, and it saved obviously precious bed space. So with that in mind, the teams set up the acute respiratory hub, using the experience of those community hubs, virtual wards, and took over a few rooms in ED, and then got a really robust GP-led, GP referral kind of acute respiratory hub, which essentially was 20-minute appointments for people who'd been triaged over the phone. So either kept them away from their local GP, freeing up space, stopped people just presenting to ED. We gave some people in that grey area where they're not quite sick enough to come to ED normally, but they probably don't need to be seen by their GP. So where do they sit? So they sit here. So obviously people with respiratory infections, and it worked really well. I think there was like 1,800 patients seen in that 3-month period from like beginning of January to the end of March. There was a number were admitted to ED, actually deemed to be sick enough. Majority were were sent home with obviously advice about seeking help from the pharmacy, or kind of just managing symptoms with paracetamol, etc. Again, which fed back to the information from kind of the national statistics that during some of the winter surges, traditionally probably 40% of people with respiratory infection that go to ED are just sent home. So can we manage those people who don't really need to go to ED and free up people who really do? But then we saw the impact of rapid diagnostics. So initially used a kind of an automated rapid lateral flow for just COVID to help admission to virtual wards. But then, luckily enough, to get the new iteration of our syndromic testing, which was the Spotfire, 15 pathogens, 15 minutes, to see how that type of diagnostic could be impactful in this particular pathway. And within a week's worth of use, I think it was 33 patients seen. I think we had about 20 positives, flu, SARS-CoV-2, Group A strep. It was at the very end of the kind of childhood Group A strep, scarlet fever kind of little epidemic we had in the UK. So that helped manage a number of really quite unpleasant sore throats. But one of the things that was very key to the clinicians that were running that service is don't do a diagnostic if you don't know what to do with the result, or if it wasn't going to change your management, because resources are tight. We don't want to waste, because if we waste the money using diagnostics, it dilutes the impact of diagnostics. So people might think that's counterintuitive. If you're not using it enough, people think, well, therefore we don't need it. But that's not the case. If you test everyone, you're going to get a lot of results you don't know what to do with. And therefore the utility and the significance of those results get diluted by the rubbish. So I think it's really ensuring that we use diagnostics correctly. So really good diagnostic stewardship, the right tests on the right patient, and know what to do with that result. Is it going to change how you manage them? The big panels can help with antimicrobial prescribing. Obviously these patients it's not the only thing that is within their management. Obviously they're getting clinical measurements, physiological measurements of temperature, respiratory rate, pulse rate, blood pressure, etc. How they present, along with diagnostics. So, if the panel is completely negative for the viruses, could they potentially not need an antibiotic? Can this be aligned with some rapid biomarker like CRP or procalcitonin to say, well, actually, they probably don't need antibiotics. Go home, but if you come back, if you feel really sick, come back to ED. So I think COVID pandemic and respiratory virus testing has been a real hotbed for innovation, different ways of working, ripping up the rule book, trying something different. The power of, engaging with teams. This is not an ego trip for those people who think they've got the best ideas. It's about working collaboratively. In the end, it's patient first, and we're here to kind of use our experiences, our creative ways of thinking to best improve the patient journey and the patient experience and patient outcome.
Yeah, so it sounds like that change that comes in on, gone from bed management to patient management. And one of the things you mentioned there was that, clinicians would be more likely to act on the result if they have it before they prescribe. So when you bring in a change such as that, going from no molecular diagnostics to that syndromic panel where you have lots of options available to you, how important was it to have that conversations with the clinicians, or was there any other stakeholders involved in that? Because it's one thing to have the result available, but it's another thing to have people who are willing to act on it and put their trust in that result.
Absolutely. I think if you break down the diagnostic pathway to pre-analytical, analytical, and the post-analytical, it opens up different stakeholders to work with. If you think that the diagnostic is the test itself, kind of looks after itself, it's the pre and post that can be the most challenging. You could have the best test in the world, gives the greatest result in a short period of time, but if you aren't able to give the result to the right team in a timely fashion that impacts patient management, this point is worthless. The investment is not worth it. So I think it's really key. We're not here to impose what we think is the best way of working onto the clinical teams. We've got to go and ask those questions. We can obviously, we come up with the ideas and go, what do you think? So yeah, engagement with the teams are going to use it is really important. One thing that's been really key is that you engage with the clinical team, but it can change over time. So we've gone back and audited and got some really good data on, for example, our pediatric use of the respiratory panel. And we've gone back to look at its impact. Was the result given in a timely fashion? Was the patient even still in the hospital when the result came back? Did a result that clearly indicated a viral infection stop or not have an antibiotic prescribed? And then if certain factors were suboptimal, to go back to the team and say, is there anything we can help, or was there a reason why? And then kind of have that dialogue is really key. So you're absolutely right, is a really key part. And then just algorithms on who to test. Now we have to be a bit strict as our budgets are cut. We have to then guide people on how best to use it. And they will say, well, actually, sometimes we said, well, this group probably work. They actually, well, not really. We can manage those clinically. We probably don't need to test them, but we feel we need to test this group, and we'll support them in that.
Yeah, so I suppose it kind of has this new way of kind of almost looking to bed management has helped that infection control aspect and also the stewardship side of things. So would you have seen kind of the reduction in your antibiotics, or I suppose even that comfort to discharge, as you say, that you're sending an unwell but not too unwell patient home, someone with the sniffles?
There has definitely been a reduction in antibiotics when we've been involved in giving the results to the clinical teams, with obviously a host of other tests, so obviously biochemical tests, blood tests, etc. together. We think this is definitely a viral infection, stop antibiotics, and we've got a virus that says otherwise, confirms this. Obviously, the panels aren't foolproof. They don't have every bug that you're looking for. So obviously there are certain caveats, which is why you give advice. It's not a test in isolation. There's lots of other things that you use to make your differential diagnosis. But I think we're certainly going to be looking back at our prescribing practices. I think that everyone's went a bit haywire during COVID. Everyone got a lot more antibiotics than they should have done. And yeah, having those extended panels can help with the prescribing or not prescribing, which is stewardship is really important. And obviously there's a drive to reduce inappropriate prescribing for our kind of response to rising AMR and the AMR programs that we have running in the Department of Health and NHS. And having really good diagnostic syndromic panel can really help with that in appropriate patient groups. I think I think that's going to be really key and really interesting. So yeah, where we've proven it's a virus, we don't need to use antibiotics.
So this was a big change, moving to 24/7, but was there any support that came from our side maybe that was helpful for that? Was there the training, or how would you see having a company like BMR as a partner in something like this was of benefit?
Very much so, because obviously we had a number of established assays. Obviously, we were quite an early user of the BioFire film array. So as soon as kind of COVID hit, for example, we were like, when are the panels going to be released? And we actually were part of the evaluation and the data collection for the regulatory approval. So we had a very good relationship with our local representatives. BioMar is in Basingstoke, which is very handy. So there's obviously been a good relationship anyway. And I think it's good to have trust, because there's a lot of, poor tests that get thrown around in these types of times. So having those relationships with partners like BioMar are very important. And, the support of trainings are key, because, we had a lot of very inexperienced staff that were joining the teams, particularly to help with the response, and have subsequently embedded into teams working 24/7. You need to ensure that your staff are well trained, they're safe, they're competent, they understand what they're doing with the results. So that kind of quality aspect is really key to having really good training, really good support. These things do break down. It's and having that really key technical support and preventive maintenance was really key. So having almost next day service for things when they're really key, because diagnostics go down, patients still come through the door. They're not going to stop because your tests have stopped. So that's been very key for us. And obviously having something that you believe that result.
Spoken a lot about the impact in terms of patient management, a little bit about stewardship, infection control. If you could step back and allow yourself a few minutes to be, proud in what you've achieved, is there a highlight to that, or is there an overall impact that you kind of say that, yeah, this is because of the team, the change that you made?
I think, stepping back the last, say 5 years, because we were starting to really think about how we can improve our services before COVID hit us, using the new technology that was coming to us. I think very key to point out, this has always been a big team effort. We're all bring our own skills to the table. We've had this kind of cumulative count of how many respiratory tests we've done over the last 4 or 5 years. And, it's got a dashboard that helps with patient flow and patient management, or mainly bed flow, actually. And seeing those numbers tick up, thinking, wow, this gives you a bit of context. When kind of COVID hit us, we had our molecular team was 2 people with 1 extractor, 1 PCR machine. Okay. And obviously we'd just literally probably had just got a film array, the Torch, and now we've got a whole laboratory. So seeing that transition from quite a rudimentary service that would be quite easily overwhelmed during flu season, to a very well established, robust team that can flex. So helping to be part of the mechanism that's built a really robust team that can change the way we manage patients, certainly with respiratory infections. But then I think helping to kind of spread that philosophy around to other colleagues around the country, and being there to kind of help improve those diagnostics pathways around the country has also been really quite privileged that people listen to us. We're not a huge tertiary referral hospital. We're not a big university hospital. We're a DGH, but I think we punch well above our weight because we've got a very supportive, innovative team, but also the structure within our trust is very supportive of innovation.
That brings me on really well to the next question, which is what's next for this great team? You know, any future plans to develop either from the diagnostic side of things or use that kind of concept of near patient testing to improve?
I think the concept of near patient testing is really exciting, and there are so many, we can grow that for sure. It's just a lot of these services are still embedding, and those ways of working are still relatively new, because you remember a lot of these clinical teams change quite a lot. People move around as they train, so staff aren't static. So you always constantly have the challenge of keeping people trained, keeping them competent, which I think why there's a good mix between near patient and point of care. You can't put everything point of care, but you also got to understand you need to have something nearer the patient for that impactful, rapid result. So I think I like, the point of need kind of picks that point of care and near patient quite well. So you're providing a service that's at the point of need. It doesn't necessarily have to be at the bedside, but it can be in a place that has an impact. So little hubs, or in an acute respiratory hub, either in the ED or out in the community that you have a relationship with. I think, how do we learn to live with COVID and other respiratory viruses? How can we use it to better inform prescribing? And that comes around a lot of education with clinical teams about, there's a great test, but how do we use it to this? And then bring in things like biomarkers to help aid diagnostics. So it's not just about the bug, but it's also about the human response to the bug to help bring that together. I think that's quite exciting. That's where we want to go, is how we bring the biomarkers in with the rapid diagnostics and syndromic approaches. And not just with respiratory viruses, but things in sepsis as well. I think that's really interesting.
So where or how do you see that Spotfire and that adaptation fitting in that model?
I think the panel is the right size. The larger panels are really interesting, but you don't always need such a big panel all of the time, as we've discussed. And obviously, making the effort to bring something down to 15 minutes, its most impactful use and of benefit of the time is to have it nearer the patient part of the journey as opposed to near the lab. And so I think I obviously saw it for a short period of time, how impactful it was in an acute respiratory hub where it was run by the clinician with the patient. I mean, you can play around with exactly how you do that. I think that was impactful because you're getting a result when the patient was still there. But actually, if they say, well, you've got a viral infection, this is the reason for your sore throat, here's the result. Because it's a nice, simple screen to understand. It's very, the output's very easy for anyone to understand. There's a virus. Viruses don't respond to antibiotics. You don't need to get, and then they're more likely to go, okay, fair enough. So that can help with prescribing as well.
If there's anyone who's going to be listening to this who is, say, at the very start of a journey where they want to bring in syndromic testing that's point of need, is there any little words of advice or something you've learned along the way that you'd want to share with them?
I think the training aspect is really key. So, I mean, it's you got to work with all the stakeholders who will be involved in that patient pathway, decide as a group where you think that diagnostic should be placed, who's going to run it, who's going to look after it. So there sometimes is, when things are removed from a laboratory, who looks after the quality aspects of said test? Because just because a diagnostic is removed from the lab doesn't mean it no longer sits under a quality system. We still have to look after that result to know that the result is the right one, as best we can in the accepted performance parameters. So I think understanding who's going to be looking after the quality, whether that be maybe you're lucky enough to have a point of care team that is used to kind of managing testing outside of the laboratory. So you need owners and you need super users who can cascade training. And then I think a really good quality framework that has been co-produced with all the stakeholders is really key. And then I think that's one thing that is yet to be completely fixed, is what to do with the result, because you want it to go into the patient record. So you've got to ensure that you know where that result's going to be stored, and is it going to be stored correctly, and can it be accessed after the fact by other clinical teams. We don't want a patient to come to a hub, they're COVID positive, that just goes into the paper notes or the notes for that patient in the community. They come in the next day and there's nowhere it says they're COVID positive. They might be unconscious, or they could be flu positive. They could come in with a pneumonitis, go straight to ITU, but we don't have a result that they're actually positive until they're retested. So getting that IT infrastructure is really key, and that's probably the thing that takes the longest. So you want to kind of start that journey soonest with IT connectivity, because also, there's a regulatory requirement to report our SARS-CoV-2, our notifiable diseases to UKHSA as well. So you need to don't forget those bits, which are bread and butter in the laboratory, because we've got a system which talks to those IT systems. Sometimes people don't always remember that for point of need or point of care, is they forget about that connectivity part. Don't forget infection control, don't forget IT, and don't forget quality. I think,
We're just obviously about to hit winter season, respiratory season. How do you see the diagnostics playing a part for this season and for the future?
I think one of the things we've learned from the COVID pandemic is the traditional diagnostic pathways might not be the answer to everything. So thinking outside the box and creating new use cases, I think, could be very useful. And the challenges to hospitals during respiratory season is very busy ED departments, very busy pediatric clinics, daily clinics. So how can we reduce that burden that can be entirely appropriate, but how can we support that with diagnostics? So I think moving diagnostics, particularly rapid, accurate diagnostics, that are easy to use, closer to the patient need, and also closer to primary care. So intercepting people before they get to ED or before they go to their practitioner, either in acute respiratory hubs or community diagnostic centres, pharmacies. I think that's where the future of respiratory diagnostics is getting to people before they present to hospital. I think that's where it's going to be really exciting.
Kind of trust in the accuracy of the result, and then actually decide how best to do that. So this is not isolation. This is multiple sites that might have slightly different patient cohorts, because obviously you don't want to there's a lot of different practices in the UK based on different patient cohorts and different populations. We're so how people present, how people are tested, how we report that result is always going to be very different everywhere you work in the NHS. So, but there will be some common factors, and it's when do you establishing the criteria around when to test and then what to do with that result is always key to diagnostics. And I think sometimes that's lost in a little bit in microbiology. There's so many testing that's done in infection where people generally don't know what they'll do with that result, like a lot of a fishing exercise, which is not an ideal way. We need to kind of get back to first principles on, if you're going to do a test, it should be because you're looking to change the management of that patient. So I think it's really key. And of course, you're always going to get pushback from clinicians as they understand the technology you're providing. So that's why it's really key to have good relationships with the teams that you're looking to work with, because if you've got that rapport and the trust in your experience, and they will trust the kind of information you're giving them, that makes things easier. So having that good rapport is key. You're always going to get some pushback, and that takes time. We all have different practices, we all have different experiences of using different tests, good or bad. So just managing those expectations is key, but open dialogue is always key, and then obviously being open to audit as well, to kind of see the impact.
Thanks, Steve. I hope that's answered Tom's question. The next question I have there is, so how has the move to 24 hours impacted the service post-pandemic? Because obviously we spoke that was the change during the height of the pandemic. So now that things have, we won't say calmed, but seems to the new normal, how is that impact carrying on?
Yeah, I mean, it's a good question, because I appreciate everyone operates differently in the NHS depending on their workforce and the budgets and the amount of samples they test. We obviously saw an impact of having 24/7. There's a lot of patients who do present to ED out of hours. Obviously not as many as during the day, but and also there's a lot of bed moves at night, and you'll be surprised how many people actually get discharged in the middle of the night when step down testing to be released, for example, to care homes, which is still a statutory requirement. It is required. Sometimes they just, some of these can be unplanned when packages of care come up quicker than they expect. So we have seen that impact. However, it is an expensive service to run 24/7, as you can imagine. So we've actually stepped down the full testing 24/7, but we have acknowledged that some testing during the night is important. And one of the ways in which, we've always wanted to have satellite labs away from our main laboratory, because we've seen that impact, especially on infection control related testing, C. diff, norovirus, etc., etc. So we started to augment these labs with not just respiratory virus testing, but some of these as well, to show the utility, because we were aware that funding was going to run out and we needed to show that it was worthwhile. And then also moving to putting blood cultures. So whereas the respiratory testing is no longer 24/7, we have shown that things like blood cultures being loaded in the night with multidisciplinary BMS is important, and we're starting to kind of show that. So maybe it will open again, but the full service was closed because it was not affordable, and also staff move on, because a lot of these staff were temporary or on fixed term contracts.
I think I don't know if anyone in attending has any questions, but I think that move around that 24/7 and blood cultures is going to become a lot more topical with recent guidelines. Does anyone want to raise their hand or add any other questions to the Q&A, or have I missed any in the chat? I don't think so. I open it up. I know we're kind of at time anyway. So if anyone does want to add anything and there's anything we can forward or come back to, if Jamie wants to close us out there, 3 minutes to go.
Yes, I will do. Well, it just remains to say thank you very much, Stephen. That's been absolutely fantastic, and thanks to all of you for joining us. Just one last thing as well. This, of course, is only the first episode of 4. So we're hoping that you will join us next week, next Wednesday at 12:30 for our episode with Sue Lovegood, talking about full lab automation. And the QR code that you can see on screen there, hopefully, will take you out to our landing page where you can also register for our other speakers also. So thank you once again, Stephen, and everyone who's joined us, and enjoy the rest of the day.
Thank you.
Thanks, everyone. Have a good day.